Hello, everyone. Welcome to the wonderful world of economic evaluation. The purpose of this lecture is to frame the value of economic evaluation within the movement to universal health coverage, to introduce the more common questions asked within any economic evaluation, to introduce the core components of economic evaluation, and ultimately to bring these concepts to life through application to a case study of priority setting around a new cancer drug. So this is the outline of the lecture today. In part one, we're going to speak about the role of economic evaluation in universal health coverage. And in part two, we're going to define economic evaluation. We're going to go through the core components of economic evaluation and speak about the interpretation of economic evaluation results. So moving swiftly into part one, which is all about the role of economic evaluation on the pathway to universal health coverage, or UHC. And to get us into this, I'm going to introduce you to two frameworks. The first is the Coutson framework, called Pathways to UHC Goals. And what I like about this framework is it really summarizes the UHC intermediate objectives of equity, efficiency, transparency, and accountability. And it shows us how we need to choose our benefits. In other words, our medicines, our vaccines, our diagnostics, and our models of care, we need to choose them wisely in order to achieve UHC objectives. And this is where economic evaluation comes in. The next framework is the UHC cube, which I really like because it helps us to understand that within any health system, there are always going to be trade-offs between the benefits, in other words, the medicines, vaccines, diagnostics, or models of care, the benefits, versus the quality at which one can deliver those benefits and whether they can be available on an equitable basis. And then I'm going to end off part one with a summary. So what is universal health coverage? The definition I like is that UHC is about providing all people with access to needed health services of sufficient quality to be effective and to ensure that the use of those services does not expose the user to financial hardship. The goals of UHC, therefore, are access to quality services when in need and financial risk protection. In other words, protection from catastrophic healthcare expenditure during the use of health services. So here we have the Coutson framework, otherwise known as Pathways to UHC Goals. So here on the left-hand side, you get my pointer, here on the left-hand side in the blue, you have different health financing arrangements to do with revenue collection, pooling, and purchasing, and importantly, this then leads to those benefits, those diagnostics, those vaccines, those medicines that are part of the UHC package. And if those benefits are chosen wisely, one achieves equity in resource distribution, one achieves efficiency, otherwise known as cost effectiveness or value for money. And if one does this well within a fair process, one also achieves transparency and accountability, and one can increase the extent to which the public trusts the public health system. And if all that goes well, then one achieves these goals, which basically are the same as what comes straight from the definition, which is utilization relative to need, of care that is of good enough quality to be effective, and also protection for the population from catastrophic spending, in other words, known as universal financial protection. Here is the second framework, which I mentioned, which I'm going to call the modified UHC cube, which helps us to understand the trade-offs that any health system faces between the benefits, in other words, the medicines, the diagnostics, the vaccines, the models of care, so the benefits of the system, versus equity and quality. So in this picture at the moment, imagine here that we have about half of the known effective services in the world. So obviously there's a lot of things that can be offered in healthcare. And so this is a bit of a thought experiment. The idea is that this particular health system has about half of the known effective services, as shown on this sort of diagonal axis here. Also, this health system provides those services or those benefits to about half of those who have a medical need for those services. So it's not particularly equitable. And the quality that's provided is of moderate quality. And what's important to note is that there's a particular budget available, and all health systems have budget constraints. It doesn't really matter how wealthy you are, all health systems have budget constraints to do with the amount of money that is raised predominantly through tax revenue or out-of-pocket payments or other forms of financing. But irrespective of where you are in the world, you always have a budget constraint, and choices always need to be made about how you're going to spend your money. In contrast, imagine that this now is that same budget, that same amount of budget, but it's now being spent in a different way. And so now the budget is covering only about 10% of known effective services, so the benefits are quite reduced in comparison to before. However, those benefits are available now to about 90% of those in need of those services. So many people would say that this is now far more equitable than the previous situation was. And also in terms of quality, those benefits are now being delivered at a higher level of quality. So for me, the shape of the UHC cube really helps us to understand or reveal our preferences about the trade-offs that all of us face between the breadth of benefits, so how many different kinds of diagnostics, how many different kinds of medicines, what are the vaccines, and what are the models of care. So what is the breadth of benefits versus the extent to which it's available on an equitable basis, and whether we're able to achieve inequality. So to achieve UHC, which is really about moving towards universal, i.e. equitable access, so to achieve equitable access, we need to be purposeful about choosing our benefits in order to achieve equity with quality. We may not be able in South Africa to provide the same services as are available in the United Kingdom, but the goal here is to provide whatever we can afford to provide on an equitable basis. That is what UHC is all about. Of course, this notion of a benefits package is very, very complicated, and you can imagine that it's an absolutely massive list of the services available within any health system. I think that it's useful to think about these benefits being defined through standard treatment guidelines, through essential medicine and diagnostic lists, but also to note that these benefits rest on a health system platform, which includes health facilities, laboratories, information systems, district managerial structures, etc., etc. And so while it's a little bit more straightforward to understand the cost effectiveness of alternative medicines to treat a particular condition, for the purposes of this course, we also need to understand how we evaluate the cost effectiveness of the different platform components. And that is going to be what I'm going to talk about during my next lecture. So to summarize part one so far, the choice of benefits should be based on the relative efficiency of these options and whether the budget impact is affordable for all in need. In other words, we're choosing our benefits that we can provide on an equitable basis, and we are acknowledging that in every health system there is scarcity and there is a limited budget, and the idea is to spend that budget in a way that achieves our goals. Another point to summarize is that answering all of these different questions about equity and affordability and cost effectiveness can be achieved through economic evaluation. It's quite a complicated methodology, but it really is a powerful methodology for considerations of moving towards universal health coverage. Of course, economic evaluation is not the only thing that you're going to do in choosing your benefits. prior questions will already have been answered, including, is the proposed benefit safe and efficacious? And is it effective? Does it actually improve health? So normally we answer those questions first before we move into a consideration of the cost effectiveness of the intervention. So that's the end of there's one more slide for part one. So the way in which this process and evidence is organized to make these decisions is something that's done within a process that is generally called health technology assessment. So health technology assessment is a procedural thing where evidence is brought to bear within a particular framework in order to make transparent decisions that then basically enable for accountability and trust to be developed within the health system. Okay, so now I'm going to move on to part two of this particular lecture. And part two is going to be all about economic evaluation. So we're going to answer the question, what is economic evaluation? What are the core components of economic evaluation? How do we interpret economic evaluation results? What is a cost effectiveness threshold and where does it come from? And then I'm going to summarize again. So what is economic evaluation? The very standard definition is that economic evaluation is the comparative analysis of alternative courses of action in terms of both their costs and their consequences or outcomes. So this idea is that we are comparative and we need to focus on different ways of doing the same thing. So courses of action or alternatives respond to a particular healthcare need. For example, different medicines to treat a particular condition, different diagnostics to diagnose a particular condition, different vaccines to prevent a particular condition, or different models of care. For example, which is more cost effective? Is it better to have facility-based antenatal services or home-based antenatal services? And again, for a particular condition, in this case, the condition would be pregnancy. So it is important to realize that at least two courses of action need to be included in each economic evaluation. Often an economic evaluation will be 3 or 4 or 5 courses of action, but the minimum is 2. And normally you define a baseline or your first option, and that would normally be standard of care, whatever the current practice is within the particular health system where the evaluation is being done. And sometimes current practice may include do nothing. However, do nothing is not necessarily associated with zero costs or zero outcomes. But if nothing is being currently offered for the particular condition, then do nothing is the appropriate standard of care. And then we introduce an alternative course of action, and that is normally something new that we're considering including within the benefit package or within the health system. So here in this table, I've summarized 3 examples for you and related them to specific diseases or conditions. So the conditions are HIV/AIDS, human papillomavirus, and HIV-associated cryptococcal meningitis. And here we have the status quo, and these are just examples. So these are not the only status quos available or alternatives available for these 3 conditions, but these are examples. So for HIV/AIDS, the status quo might be one particular drug called D4T in first-line treatment, and the alternative we're considering might be TDF or tenofovir in first-line treatment. For human papillomavirus, the status quo might be do nothing, and the alternative might be the introduction of the HPV vaccine, which is quite effective at preventing human papillomavirus. And then thirdly, for HIV-associated cryptococcal meningitis, the status quo might also be do nothing, and the alternative might be to introduce a particular way of screening for cryptococcal meningitis and to evaluate the costs and benefits of that. So those are 3 examples of how we would frame the status quos and alternatives within 3 economic evaluations. So what are the main evaluation types of economic evaluation? And now there are quite a lot of other types of evaluations, but for the purposes of this course, we want to help you to understand the main types so that it's not too overwhelming. So these main types are cost analysis, which again is comparative, and we can define it as the comparative analysis of alternatives in terms of their costs. So the costs of the status quo versus the costs of the new alternative intervention. The second type is cost effectiveness analysis, which is also comparative because they're all comparative. So the comparative analysis of alternatives in terms of costs and health outcomes, where in cost effectiveness analysis, health outcomes are unidimensional in nature. And I'll explain more about that in a bit. The third type is cost utility analysis, which is the comparative analysis of alternatives in terms of costs and multi-dimensional health outcomes. So you can see that the main differences here between the three are that firstly, cost analysis does not look at health outcomes at all. Cost effectiveness analysis looks at unidimensional health outcomes, and cost utility analysis looks at multi-dimensional health outcomes. But irrespective of which evaluation type, all of the results are expressed on a per patient basis, where that needs to be defined for the particular evaluation, but it's on a per patient basis. Then I would like to introduce you to two other evaluation types that we think might be useful for you. And these are the costs of scaling up. And what this analysis does is it takes us from a cost per patient to the total costs for a defined period of time for all of the patients in need, so for a defined population of patients over a defined period of time. So it might be something like the cost of providing antiretroviral treatment to everyone in need in South Africa during 2020. That would be an analysis of the costs of scaling up. And then in addition to that is the budget impact analysis, which now takes those costs of scaling up for 2020 and compares it to a relevant budget or estimate of expenditure during 2020. And typically what it does is it then says, in order to provide antiretroviral treatment in 2020 to all populations in need in South Africa, one would need to spend, say, 30% of the health budget. So that's what a budget impact analysis then does. So this slide tries to summarize for you some of the core components of an economic evaluation. In the orange at the top, we have costs. And in any economic evaluation, costs are expressed in terms of a perspective. And the two main perspectives I'm going to talk about today are the provider perspective, which are the costs incurred by the provider of the service, versus the patient or carer's perspective, which are the costs incurred by the patient in seeking this care. In the middle, we have the alternatives that are being considered. So that's the different medicines, all the different diagnostics, all the different vaccines. And then in purple are the outcomes. And as mentioned, we can have unidimensional outcomes in cost effectiveness analysis and multi-dimensional outcomes in cost utility analysis. So as mentioned previously, the alternatives will typically be two or more ways of achieving a particular outcome, such as medicine A versus medicine B for a particular disease, vaccine A versus do nothing for another disease, or diagnostic A versus diagnostic B for a further disease. So those are the kinds of alternatives that we typically would be looking at within an economic evaluation. And then the provider costs would be the cost of providing the service. So that would include all the health workers, the medicines, the investigations, the equipment, but also the facility, so the platform where the service is provided is very much included within that cost. So one would have things like overhead costs, costs for water and electricity, costs for the building, costs for furniture and equipment, etc., etc. From the patient perspective, typically what one would look at is what is the opportunity cost for that patient of the time that they have spent visiting the health facility, the time seeking care. Have they incurred any out-of-pocket payments? That could be things like user fees in particular contexts, but it could also be things like transport costs. It could be things like food that was purchased while waiting for services. It could even be things like accommodation, if one has to wait for a long time or if one has to travel from a far distance. For the outcomes, unidimensional outcomes are also known as natural outcomes. And so it's often very closely mirrored to the outcomes that you'll see within a clinical trial. So things like delayed disease progression or deaths averted or suppression of the viral load would be unidimensional outcomes that can be included within a cost effectiveness analysis. And then multidimensional outcomes are the quality adjusted life year or the disability adjusted life year. And what those do is they take the outcomes and they express them in a way that makes it comparable across different kinds of diseases or different kinds of patient groups, so that now one is able to say, or one is able to compare between, for example, HIV and TB, because the health outcome is expressed on the same measuring rod, being the QALY or the DALY. And that then is the basis of the cost utility analysis. So to summarize these components so far, the costs are the resources that are needed to provide the service per patient for each alternative that's considered. And the perspective can be the provider perspective, the patient perspective, or the societal, which is basically just including both provider and patient perspective. So the provider perspective is the resources incurred by the provider of the service, can include health system and other sectors that contribute towards health. So for example, in a provider perspective, some services require the input of social workers from social development, and that can then be included. In contrast, the patient perspective includes the resources incurred by the patient and his or her carer or family while seeking care, and it's to do with the opportunity cost of time. To summarize outcomes are the benefits or health gains produced per patient per alternative, and these could be unidimensional or multidimensional, where unidimensional is typically natural measures like viral suppression, life years gained, deaths averted, etc. And multidimensional is the one that we're very keen on, which basically takes morbidity and mortality and puts it into one measure, the quality adjusted life year or the disability adjusted life year. And these multidimensional outcomes are really useful because it allows us to compare across diseases or program areas. And as I will explain in a minute, it allows us to compare the sort of benefits of whatever we're evaluating to a broader cost effectiveness threshold. And that's then what allows us to judge whether this new thing is going to be value for money for our health system or not. The analysis in the end ultimately summarizes findings as follows. So if the costs are going to be the cost per patient of option A, the cost per patient of option B, and then the difference in costs, the option B minus option A. Benefits are going to be outcomes per patient of option A, outcomes per patient of option B, and then the difference in the outcomes, again, option B minus option A. And then most importantly comes the incremental cost effectiveness ratio, which summarizes this difference in costs divided by the difference in outcomes. So it's something like $100 per DALY averted would be an example of how an incremental cost effectiveness ratio might be. Okay, and then moving on to the interpretation of economic evaluation results. And for the different kinds of forms of economic evaluation, there are different interpretations that need to be made. So cost analysis is the most basic of all, but is also rather limited in terms of what one can say or how one can interpret the results. And all it does is it provides a summary of the per patient additional costs associated with moving from one alternative to another. So moving from your status quo to your new alternative under consideration. What are the additional costs needed? Cost effectiveness analysis is a bit broader, so it also provides a summary of the additional costs. But in addition to that, it gives you the additional unidimensional health outcomes associated with the change in alternatives. Cost utility analysis also focuses on the additional costs, and now it gives you the additional multi-dimensional health outcomes associated with the change in alternatives. So what's great about cost utility analysis is that you can compare your incremental cost effectiveness ratio, your ISA, to an external cost effectiveness threshold. And this cost effectiveness threshold summarizes, it basically gives you a sense of whether your ISA is cost effective or not. So if your ISA is lower than your cost effectiveness threshold, you can say that your new intervention is potentially cost effective. But if your ISA is higher than your cost effectiveness threshold, what you have to say is that your new intervention is unlikely to be cost effective within the particular health system that you're considering. So what is this cost effectiveness threshold? So the CET captures the value of the least cost effective intervention within your given context. So the complicated terminology is that it captures the marginal productivity of your health system. And you can only estimate a cost effectiveness threshold for multi-dimensional outcomes. So it's only for QALYs or DALYs. So for a long time, we did not have any estimates of cost effectiveness thresholds available. But happily, we now have actually quite a few estimates available for low and middle income countries. So DALY-based thresholds have been estimated by Ocharlik et al., and QALY-based thresholds have been estimated by Woods et al. And so if you need to know the value of those thresholds, you can look them up in these two publications that I'm citing here. So again, the cost effectiveness threshold gives you a sense of what is the least cost effective intervention within your given context. If your ISA is now higher than that, it means that your new intervention is even less cost effective than the least cost effective thing that you're currently doing. And so it's probably a very bad idea to add it to your benefit package because it's not going to improve health and it's not going to improve equity. So that is basically the idea of the cost effectiveness threshold. So now I understand that that's all a lot of theory and it's quite a difficult bunch of theory. So I'm just going to talk through an example that summarizes cost analysis, cost effectiveness analysis, and cost utility analysis. So you can see some numbers, and hopefully for some of you that will make things a little bit more straightforward. So this is now an economic evaluation that we did last year, looking at intensive care in the management of critical COVID-19 patients for the South African health system. So it was in order to inform a decision of whether or not our government should expand its ICU capacity or whether it should purchase ICU capacity from our private health system. So what we did is we compared ICU to a sort of hypothetical status quo, which is that critical patients would be only managed in the general ward. Because in fact, in the absence of ICU capacity, this is what would happen to critical patients. They would still be hospitalized, but they would be managed in the general ward. They would not be able to be managed in the ICU. So here we're summarizing the cost per admission. So cost per admission is the cost from day one of being admitted until the day of discharge or death, whichever one happens first. So without ICU, the cost per admission was about 75,000 rands. And with ICU, the cost per admission was about 103,000 rands. So what this then means is that in order to provide ICU, you're looking at about an extra 30,000 rand per admission. So that would be an example of a cost analysis. For a cost effectiveness analysis, our question then would be, what is the incremental cost and incremental effect of intensive care in the management of critical COVID-19 patients? And so what we've added here, we've still got our same cost per admission, but what we've added here is a unidimensional outcome. In this case, the outcome is deaths, because as you all know already about COVID-19, the critical thing is whether somebody lives or dies, or at least that's one of the important considerations in allocating resources. So without ICU, 27% of admitted patients died, and with ICU, that came down to 20% of admitted patients dying. And here we summarize the incremental cost per death averted, which is about 391,000 Rand per death averted. So that is our incremental cost effectiveness ratio for this analysis. However, we don't know whether that is value for money or not, because we do not have a cost effectiveness threshold to compare this to. So we know that it's a high number, but we've got no way of contextualizing that number in comparison to how else we might be using that money. So that is where the cost utility analysis comes in, which is finally the form of economic evaluation that allows us to comment on value for money. However, in order to do this, one needs to express one's outcomes in a multidimensional measure, which could also be the QALY, but in this case, we use the disability adjusted life year. Now, a DALY is a bad thing, and so you want a lower number of DALYs. And so as you can see, ICU generates 1.1 DALYs, whereas not having ICU is worse because it generates 1.48 DALYs. And this then gives us our incremental cost effectiveness ratio, which is now the incremental cost per DALY averted. And it is about 73,000 Rand per DALY averted. Okay, great. So now what do we make of that? Fortunately, in South Africa, we have a sense of what our cost effectiveness threshold is in our public health system. And we know that it is about just under 40,000 Rand per DALY averted, meaning that the least cost-effective thing that we're currently doing is generating health at a cost of approximately 40,000 Rand. So this then means that our incremental cost-effectiveness ratio, which is at 73,000 Rand, is higher than our cost-effectiveness threshold. So our conclusion then is that purchasing additional ICU capacity or building additional ICU capacity for COVID-19 was unlikely to be cost-effective in South Africa. Of course, that doesn't mean that you won't do it. There are other considerations at play, like politics, but it does mean that ICU for COVID-19 was going to not be a value for money investment for South Africa. So in summary, choices around benefit packages, including choices around medicines, diagnostics, vaccines, and models of care, are critical in the movement towards universal health coverage. Economic evaluation plays a really important analytical role in improving benefit package decision-making, and ultimately it can contribute to improved equity for your health system. It can help you to move closer towards universal health coverage. And those two notions are basically fundamental to this idea of distributive justice. Of course, these benefits, medicines, diagnostics, vaccines, etc., rest on health system platforms that include healthcare facilities, laboratories, information systems, and managerial structures. Now, your standard economic evaluation does include all of those costs, but it's still within the context of considering a particular medicine or particular diagnostic. In our next lecture, I'm going to focus on a different kind of economic evaluation, which is all about how we could look specifically at those platforms, for example, at information systems as the alternative under consideration, and how would we then determine the cost and cost effectiveness of those platforms. So that's for the next lecture. Thank you very much for watching, and I look forward to meeting you during our webinar. Bye for now.